So what is really very clear now with targeted therapies for BRAF mutant melanoma is that resistance will develop in the vast majority of patients. And so the biggest clinical challenge that we face is how to overcome that resistance. As I presented here at the EADO Congress, the approach of trying to deal with resistance once it has become clinically apparent is a huge challenge. And I put it to our field that in fact that approach has not been successful. However, there are many vulnerabilities during the early phase of treatment with BRAF and MEK combined therapy for BRAF mutant melanoma, where novel therapies have an opportunity to overcome the problem of resistance. We'll see results this year of adding anti-PD-1 based therapies or anti-PD-L1 based therapies to targeted therapy, and that is one approach, but there are other approaches as well. So what does all of that really mean for clinical practice today? I think for our patients with BRAF mutant melanoma, I think about different categories of patients and their risks of developing relapse. We know for patients with high burden of disease, liver metastases, high lactate dehydrogenase, that resistance will develop, and it will develop relatively quickly after starting targeted therapy. So clinically, one must be aware of that. One must detect progression early, or even consider in very selected patients a very early switch to immune-based therapies or enrolment onto a clinical trial if such a clinical trial exists. So we have to be aware of the development of resistance at the beginning of therapy with targeted therapy. There is, though, a second subset of patients with lower volumes of disease, non-visceral disease, that can have very, very durable disease control with targeted therapy, and those patients, targeted therapy can be very effective. Given that we have failed to deal with resistance effectively once it has occurred, we need a concerted effort in clinical trials to add in additional therapies very early in the disease course to combine or use sequentially with combined BRAF-MEK inhibition. This is going to require novel clinical trial designs, testing of several hypotheses. So what is vital for EADO as an organisation and for all the members of EADO is to work collaboratively in teams in clinical trials, enrol as many patients as we possibly can through a coordinated, collaborative effort in clinical trials. We can test these various hypotheses about the early addition of therapies in combination with BRAF and MEK to hopefully overcome this major clinical problem of resistance.